Good morning. How are you all? Um, I have two thank yous. One is to the organisers of this conference for inviting me to talk here, and the second is for all of you guys who've actually managed to stay to the very end. So, post-radical prostatectomy incontinence, what can be done? How do we move these things on? Okay, so I don't have any particular disclosures to disclose for this talk. So Dr. Harris at the very beginning of this session has sort of stolen the thunder in this first slide, which basically shows the incidence of prostate cancer within the US at the present time, with a prevalence of 2.7 million people as of 2011. Prostate cancer surgery is approximately 80,000 cases in 2008. But the incontinence rate afterwards has got varied reporting. And I think this largely depends upon how you report your incontinence. But people will say anywhere between 4% and even 87%, depending upon how you look at it. And this is immediately post-op, and this seems to reduce to about 21% roughly over 3 months. But again, it does depend upon how you actually define it. I think it's important when you're assessing people for incontinence after prostate cancer, you have to think about the stage of the cancer, whether it's advanced or not, whether people have had a radiation, because this can affect the bladder compliance over time, though I think that, as has been shown, the changes in radiation delivery mechanisms may improve this considerably over time. You also have to consider the pre-morbid state. I mean, if a guy has got a badly overactive bladder before he has his prostate cancer surgery, he's still going to have the same probably afterwards, and you have to consider this. You can have overactivity of the bladder due to irritation of the bladder or random bladder contractions. People post-operatively also have developed strictures at the bladder neck, and these strictures can sometimes be very troublesome, both in the urethra and at the bladder neck, and the bladder neck contractures can be sometimes quite difficult to manage. I think it's also important to realize that the incontinence does impact people both from a psychological point of view, where people are embarrassed and they get angry about it. They tend to socially restrict themselves and get isolated, and with loss of esteem and perhaps with loss of sexual functioning, it tends to harbour a lot on the patient's mental health. Family people also get guilt and frustration as it increases the caregiver burden sometimes, particularly in people who've got longer term things. Economically impact, it has an impact on the amount of supplies that you have to get. You've got charges and supplies for medical visits and so on, and also physical indirect costs of longer term care of dealing with incontinence, as well as the direct costs of the skin irritations, maybe pressure ulcers, maybe falls, maybe sepsis, and so on from the actual costs. People also try various drugs for overactive bladder, and you can have those, both the drug effects and the side effects of the drug. I think it's important to realize that in post-prostatectomy incontinence, while the vast majority of it is probably stress incontinence, urge incontinence, where the bladder has random activity or is driven by urgency, can have a significant part to play, which leads to a mixed incontinence picture, and I think you have to tend to treat both of these separately. Occasionally, but not often, you find people who have overflow incontinence, which is basically a constant dribble with a bladder that doesn't work, and the bladder's got a hypocontractile situation where you leak because you can't actively void. I think it's important from the point of view of assessing these individuals to get a good history from them. You need to figure out whether your incontinence is with stress activities or not. What is the quantity of the incontinence, the number of pads per day. Treating somebody with 1 or 2 pads of urinary leakage per day versus 10 pads a day is considerably different. Whether people have a sense of urgency, in other words, might they have urge incontinence on top of it? Whether they have continuous incontinence, whether they are never dry, whether people have nocturia, because what tends to happen with a lot of guys with the stress incontinence is that they lie down, the stress incontinence goes away because their bladder fills up, but first thing in the morning they suddenly have to rush to the bathroom because their bladder is now full, they've gone vertical, and the leakage starts, so they try to have a good void. Also worth finding out about sexual activity and whether they leak during sexual activity or not. Physical examination, pay attention to the phallic length, the observation of the incontinence, make sure you actually see the incontinence, because a fair number of people might complain of incontinence, but if you don't see it, it's rather difficult to fix. Whether the drip is constant or not, whether they leak with coughing, and what is the sort of quantity of leakage. Whether they have any ancillary skin problems associated with this, rash, dermatitis, breakdown of skin, what their mental state is. Some people are very anxious, some people are very embarrassed, some people are very shy about this, and you also want to get a sense of whether they're depression or not. We know from female incontinence that approximately 60% of women who show up with incontinence for whatever reason, about 60% of these individuals also happen to be on some sort of antidepressant. So it may be worth considering depression in these gentlemen. The physical exam, including a digital rectal exam, to look for local reflexes in case they might have a neurogenic bladder. The neurogenic bladder can occur due to interference of the nerves at the base of the bladder during the procedures for radical prostatectomy. So anal wink, cremasteric reflex, and the bulbocavernosus reflex would complete that examination. I think it's also important to think about urodynamics in these people, particularly if somebody has had irradiation. This is a study taken from England, where 60 men were studied after radical prostatectomy, a variable time amount afterwards, but mostly about 2 years later. 24% of them showed overactivity, another 13% had overactivity with incontinence, and urinary retention was present in about 13%. All of them demonstrated stress urinary incontinence, both urodynamically and on physical exam. A meeting that occurs about every 2 or 3 years is the International Consultation on Incontinence, and this fourth one, which occurred in 2010, was looking at male urinary incontinence, and they make recommendations about the grading of scale for recommendations regarding treatment. Basically, the sphincteric incompetence, which work best with the artificial urinary sphincter, but also has got evidence for treatment with male slings. And I will go through these later. But the overactivity is important to realize that, bladder augmentation, which would be the gold standard for really bad overactivity, by defunctionalizing the bladder, that works. But there's pretty good evidence that neuromodulation, which is the interstim device or the posterior tibial nerve stimulations, also show pretty good evidence for working for overactivity. At the time that this conference was done, botulinum toxin was showing promise, and this has since been approved by the FDA for overactivity of the bladder. But there are no studies in male post-prostatectomy. It's mainly in idiopathic incontinence in women, and also in neurogenic bladder overactivity in people with MS and spinal cord injury. Incontinence with poor bladder emptying. This is a relatively new phenomenon where people are seeing people who've got poor detrusor contractions, otherwise known as detrusor underactivity. And the key here is to ensure that the bladder gets empty, because essentially what it is an overflow incontinence. And the method of treatment of this is to drain the bladder intermittently during the day with intermittent catheterization. That is the best we have at the moment, though I understand that there are some agents that are beginning to explore in phase 1, phase 2 trials at the moment to try and make the bladder contract better. Incontinence with bladder outlet obstruction essentially needs surgical fixation of the bladder outlet obstruction to help with that incontinence. There are, in males, only one randomized controlled study prospectively done on pelvic floor muscle training. This took two essentially parallel control trials, one looking at post-radical prostatectomy incontinence, and the other one was post-TURP. This again is also a British study, where there was 1-to-1 ratio between conservative physical therapy and the physical therapists. And essentially looking at the urinary incontinence after surgery was unlikely to prevent a effective or cost-effective compared with standard care, including provision of information about conducting pelvic floor muscle training. I think that the conclusion here is that really it's based upon the scar that occurs at the bladder neck or slightly below that gets fixed in a male after his prostatectomy. And this fixation of the bladder neck keeps the urethra open, so therefore you don't have an effective sphincter. So with a stiff bladder neck and scar, pelvic floor muscle training will work very well in fixing the pelvic floor muscles, but doesn't actually close the urethra to cause apposition of the urethra and thus continence. Conservative treatments, a lot of people go for this one. It's called avoidance therapy. You know, you take out your Depends, you take out whatever brand of diaper, pad, thing that you can stick in your pants to hide the incontinence. You wear the black pants, you hide away from society, and you avoid talking about the thing. This includes also the physicians discussing this with the patients after their operation. You know, because I think what happens to a certain degree in people who've got post-radical prostatectomy incontinence is that they are very happy that they have managed to just get rid of the prostate cancer. The PSA is now 0. They have the incontinence thing, they'll deal with it, okay? But 4 or 5 years later, when their PSA is still 0 and they still have the incontinence, it's now really beginning to impact upon the quality of life, and that becomes a really major burden to them. So they now really begin to sort of think about dealing with it. But unfortunately, they've been using the avoidance therapy technique for the last God knows how long, and the physicians aren't exactly asking them about it either. Diapers cost a fair amount, you know, $100, $200 a month, depending upon how many you use. There are many types, and many of them don't work properly. They cause skin irritation, they don't hold the correct amount of urine, they leak around the sides, and you keep playing around with it to try and figure out what you get. You also have problems with formulary substitutions, and this is one that I think anybody in the VA is well aware of. You know, you get the stuff on the floor, it comes from SPD. You get the stuff from the pharmacy, it comes from somewhere else. It works well for a while, and then suddenly somebody finds brand Y, which is a little bit cheaper, so that gets substituted, and nobody tells you about this until the patients start complaining about it. Problem is that a lot of urine collecting around the skin causes rashes and may lead to other skin breakdown. But it seems that a lot of people don't want to talk about it. So I think it's important to bring the thing up directly to the patient, ask them, well, what about it? Assume that they have it, and if they tell you that they don't, that's great. I think the conservative treatments also depend primarily on what are the primary symptoms. People who've got overactive bladder, they're running to the bathroom, they've got urinary frequency, they empty the bladder well, and you know this because you can check a post-void residual. You can try the pelvic floor muscle therapies. As I said, they don't always work. You can try neuromodulation, you can try Botox, and of course the antimuscarinic therapy. But the problem with the antimuscarinics is there are about 6 or 7 of them. They all have the same side effects. It's a question of degree to the patient. If you've got the mixed incontinence where somebody's got stress incontinence as well, it doesn't fix everything. So you sort of got to fix the stress incontinence first and then add the antimuscarinics afterwards. And you tend to find that if you fix the stress incontinence, that the urge incontinence goes away some because the stimulation of the urine in the urethra goes away also. Urinary retention, got to watch out for it. I think it's important to realize this, which can be caused by bladder neck contractures, and your local friendly urologist can deal with that fairly easily with a bladder neck incision. The problem with the bladder neck incision is it'll give you really good stress incontinence because you open up the bladder neck. And this may be later fixed with an artificial urinary sphincter so long as the bladder neck contracture would stay stable and stay open, but the tendency is for these things to come back. The underactive bladder, it might be possible to treat this with intermittent cathing, but you have to watch it in the post-radical prostatectomy individual because you have to be sure that the bladder neck is competent afterwards so that they remain dry. So other things that people do, penile clamps. This is the reason why I had in the physical exam check out the penile length. There are many sorts, but they have problems fitting with fittings due to penile length, and I'll show you a couple of pictures in a minute or two. The bigger ones, particularly the cunium clamp, patients often complain of embarrassment with the object in their pants, and they worry about being in social situations with other members of their family around, particularly young kids, as to having this thing sticking out of their pants and a sort of constant, what might be interpreted as an erection but clearly isn't. And you can have pressure-related skin problems. But also in the older individuals who would be presenting with this, they have inability to use the device because of hand problems, say arthritis or dementia or something similar. This is the classic standard penile clamp, which is the original cunium clamp sold off by Bard. But the thing is, it's sort of like out of one size fits all. You clamp the thing down across the penis. This stuff is spongy in the middle, and it's sort of like one clamp, one size, and that's it, and it tends to stick. This is another device which is a little bit fuzzy at the sides, but the side clamps here allow you for a little bit of variance in the grade of how tight you clamp it. Again, foam in the middle with the penis placed in the middle. This C3 penile clamp is commercially available. You can get it in the VA system. Essentially, it's a wraparound piece of two pieces of plastic with a little notch where the urethra would go, and you fold the Velcro around. I think this is sort of nicer because it gives you a variable degree of tightness which the patient can adjust. It's a little bit fiddly from the point of view of size, and if people have got a lot of trouble with their hands or they're large and can't see down around where their penis is, it may be difficult to apply, but it works generally fairly well. Key thing to watch about these things is that you don't put them on for too long because you can get skin erosions from them. Now, the implanted devices, there's a lot of implanted devices available. Some of the ones I'm going to present are undergoing trials at the moment, so they're not FDA approved, and a lot of the data was put together in a really good article published in the Canadian Journal of Urology by Dr. Korkos. The references at the end. European guys also have a good summary of this in the European Association of Urology guidelines. So the classic gold standard is use of an artificial urinary sphincter, which is a device which has got three components. One is a valve mechanism which should go on the dominant side of the scrotum. In other words, if the guy's right-handed, put it in the right-hand side of the scrotum. If the guy's left-handed, put it in the left side. You've got a cuff that goes around the urethra, and you've got a small reservoir that goes just retropubically. This is the device out in the open, and these days they have a antibiotic on it called an inhibizone, which is an effort to try and keep down the infection rate. The review of the trials, this is 12 reports, of which 3 were prospective. All were done post-prostatectomy. About 25% of them had adjuvant radiotherapy. However, the severity or baseline of the urinary incontinence was variable across the studies and difficult to actually measure. And another problem with success in all the incontinence trials is trying to figure out, okay, how do you define dry? Do you define it as dry, absolutely bone dry, no wetness at all, no leakage in the pad? Or do you accept 1, perhaps 2 pads a day as being acceptable leakage, or the patient considering that they are improved enough so that they feel happy about it? But the point is that there's a whole bunch of different questionnaires, and there's pad tests that are used with variable degrees. Unfortunately, the success rate can be defined anywhere between 4 and 86%, depending upon how you define what your endpoint is. If you want total bone dry, then you're going to be at the lower end of this. If you're prepared to accept a small amount of dribble or a small amount of leakage, then you can get quite a high rate. Generally acceptable social continence dry rates somewhere between 61 and 100%. The problems with these devices are erosion and infection. This is most commonly caused by somebody sticking a catheter into the individual because he's in hospital for some other reason. The catheter erodes the urethra over the cuff, and this is because the cuff hasn't been deflated beforehand, because these devices can be deactivated and not using a small catheter. They use a big sort of standard 16 or 18 French catheter, and you put it down there instead of putting a 10 or 12 French catheter, which you might be able to get away with for a short period of time. Mechanical failure rates, this is where you get leakage between the joins in the devices, or the device fails to operate, or you get a thing called auto-inflation, where it means you have to replace the device. There's this other problem which can be quite troublesome, which is urethral atrophy, where the muscle that's between the cuff and the urothelium of the urethra atrophies, and you'll get loss of coaptation of the urethra, so people leak afterwards. Overall, over a 2-year period in these trials, which was the minimum follow-up, and the longest follow-up was about 25 years. The reoperation rate was roughly about a quarter of the individuals. Anyway, that's it for the standard, gold standard of incontinence. This is generally indicated for people who've got really bad incontinence, people who are in the 5, 6, 7 pads a day range. For the most part, the rest of the slides deal with some form of compression device around the base of the urethra, otherwise known as a sling. And most of this seems to work best as an overall category for people who've got sort of like 1 or 2 or 3 pads per day incontinence. The first one here is the advanced male sling. It's essentially a transobturator sling that goes through the obturator foramen down behind the base of the bulbar urethra down here, and then back out the other side. This was an advance over a thing called the invance sling, which is a male sling that just went over the bulbar urethra and was tacked into the ischial tuberosities and inferior pubic rami and superior pubic rami. The problem with that is it tended to get a lot of bone pain from the suture screws that were placed in the thing. It had to be tied down really tight, and it was difficult to get it to work properly. The registration trial for this, most of the people were after prostatectomy. A number had irradiation as well before. The severity of urinary incontinence was considered mild or moderate in most of the cases, and a number of them, about 1/3, were severe incontinence. The definition of success for these registration trials was 0-1 pad for security reasons, and the idea behind security was just somebody thinking he might leak but wasn't actually leaking, and the success rate was around about 3/4 or so, which is the same for the social incontinence rate. The complication percentages appear to be a lot less, and the mean follow-up was about 4 years. This was an advance on this one. It's a 2 sort of slings wrapped into one with a pad going across the bulbar urethra, eye stops, transobturator sphincter. And this one, again, mainly post-radical prostatectomy was used. It was a European trial, so they used the International Continence Society modular questionnaires 4 to 6, and they considered 0 pads a day as being dry. Its success rate was somewhat less, around about 60%, but social incontinence rate was probably 1 or 2 pads per day. Or 1 pad per day was 80%, just about 80%, and it had no real problems with its implantation. But the mean follow-up on that was only 1 year. So, given that, this company Argus tried another sling system which was adjustable, and the idea here was that you had these two, you had a pad around the bulbar urethra here, and then these 2 PVC stems on the pad, which you could push down this stopper-type device to pull the thing tight around the urethra, and potentially you could adjust this a few days later. Again, 100 people tried, mostly post-radical prostatectomy, about 20% with post-radiation. Severity was people with 2 pads per day is considered moderate, and those with greater than 2 pads a day. Dry on a pad test. This is really sort of a fairly stiff test, a fairly rigorous test for dryness, and it had a success rate of about 80% or so. A lot of them ended up getting explanted. There was a good number of people who ended up with erosions, and about 3% had infections, and the mean follow-up was a reasonable time of about 2 years or so. This was a neuro one. I'm not sure that it's actually approved by the FDA yet. Basically, it's called a balloon system. And essentially what happens here is you put in two balloons beside the urethra up at the bladder neck, and then out on the front wall of the pubic bone you have these two little stopper things which you can inflate with saline or water to inflate the balloon beside the bladder neck with the urethra. This was actually invented by the same guy who developed the artificial urinary sphincter for AMS, but he is doing this on his own in the PROACT balloon system. The trials in this were 128 people with 93% of them having prostatectomy. Variable degree of incontinence, but mostly moderate incontinence, which again will be defined as around 2 pads per day. Definition was reduce it down to 1 pad or a security pad, and the success rate was about 2/3%. Again, a fair problem with explantation. About 18% of them end up getting explanters. Some of them eroded into the urethra or the bladder due to the location where the device was, and you also had an infection problem as well, running about 8.5%. Because the device was placed next to the bladder and there was nothing to sort of hold it there, there was a migration problem about 5%. And then during the actual placement, there was a 4% incidence of urethral or bladder perforation. But its duration of follow-up was a lot longer. It was 4.5 years as its mean follow-up. So sort of encouraging for it, but not totally great. This one, the Adams device, again, I'm not sure is FDA approved, is a device that's a combination of a transurethral transobturator sling with a little inflation device placed on the sling pad. So you have the device put in, and then later the pad or inflatable part of the device will be inflated to an appropriate pressure to stop the urine coming out. Its registration trial, again, mainly post-prostatectomy incontinence, with about 1/3 with the radiation involved. Moderate to severe incontinence was primarily used. Severe was greater than 2 pads per day. They had a pretty rigorous definition of success, 0.1 pad for security and a 24-hour pad test of less than 10 cc's of urine loss, which is really quite dry. They defined 63% of the cohort as being dry, but they didn't report a social continence rate. They had a 4% explantation rate, which is probably related to the infection rate, and a couple of people had urinary retention from it. I suspect that could be resolved by reducing the amount that was in the inflatable part of the prosthesis. Now, just to finish up, there are a couple of other things that are out there that are not in good use yet. There's this device which is not made by AMS, but is a single-piece artificial urinary sphincter with a cuff and a inflation device for the scrotum. There's one being developed by my colleague Craig Cometer at Stanford, which I have nothing to do with, which is a 4-wing transobturator and suprapubic sling, which goes around the bulbar urethra more comprehensively. This is undergoing trials at the present time. And then there's periurethral cuff constrictor, which is essentially you put it around the urethra and you can manually inflate it using a saline valve mechanism that is placed above the pubis. And then Dr. Korkos is developing this remote control sphincter for the individuals who've got the problem trying to get the sphincter valve mechanism from the AUS managed because of arthritis or difficulty with their hands or difficulty reaching it. So overall, in summary, I don't think that there's a really totally perfect solution for post-radical prostatectomy incontinence, but we can certainly improve the situation considerably. I think one of the problems with the post-radical prostatectomy incontinence is that it's highly variable reporting of the subject, and generally there's no fixed or accepted definitions that are used consistently across all the trials, which makes comparison to the trials very difficult. I think the other problem too is there's likely fairly conservative estimates on incontinence post-prostatectomy due to the hided features of people's attitudes towards incontinence. but it is known to lead to many mental health problems, some social isolation, depression, and so on. But all the treatments overall do seem to be able to improve or provide improvement of the current situation. Whether this is acceptable to the patient or whether it's acceptable to the physicians as a long-term solution, I think still has to be defined. Thank you very much.